Here, his date of birth is 11/30/89, and he is here for left eye cataract surgery in this case. Left eye. All right, and under diabetes. Diabetes.
Winter's on, left eye, platinum. Not blocked. Leather coat?
I do not.
Right in? Okay.
Standing up.
What power is? 14.
0, keep at 40 axis, 105.
Can we go ahead and
Go ahead.
First that on left eyes. We want to do that on the right eye. We'll just switch the observer scope over.
Okay. Hey, it's Matt. How you doing? Hey, are you comfortable? I'm just gonna adjust your head a little bit. Chin up for me.
Yeah,
Good.
somewhat comfortable after the IV.
Julie, have you discovered the little adjustments on the bottom of the headrest here? Really helps me to get the eye kind of horizontal, which can help to get, like, if they've got a heavy brow or the chin tucker or the hyperextender, get the thing just right. They were on the bed all this time, and I only figured it out like 6 months ago. There's two of them. One here. It's like a little clutch, like a little, like a brake lever that you pull.
Can you bring my headrest
He doesn't love
up
it.
a little, just a small amount?
Sure.
That's good. So that works for you, shit.
I guess the one on the left is like the lower neck, and the one on the right is like the top of the head. Is that gonna work for you? Okay, we're gonna bring in the microscope. Everybody likes the tilt a little bit different. Yeah. But as long as it's like kind of on the visual axis, I think you're good. Will you raise the bed up a little bit so I can get my legs under there?
Good. I feel like
That's good.
comfortable or like a sharp pain. What should I say to?
Just make like a grunt. You can say ouch. Just keep your body still, right? Okay, Julia, do you want to adjust your oculars there?
You're not putting like a scalpel in my eye, are you?
Do you really want to know all the details? We actually use a little finely honed gemstone, only a millimeter in width.
Okay.
So they're technically not scalpels. It's called a keratome, but it is an edged instrument. We just make two little ports on the eye, but they're teeny tiny and they seal with water pressure.
I didn't know.
Yeah. Okay, Zoma.
I'm pretty much ready.
All right, man. Just kind of look like straight toward the ceiling, okay? That's perfect. Exactly right. So I like to get my hips situated first because I don't want to wind up with a bad neck. you know, and then I'll kind of get the chair parked. You like to use the stools or the? You're a lot more stable with this one, just when because you don't have to like keep your hips at the right distance of the patient. It's like a little easier on my neck. Yeah. Oh well, if the surface is slippery, there's some sandpaper, and you can just have them sand the surface. Then you stick a lot better to it. So when I make the para, I like to press down on the speculum like this, because that prevents the eye from deflecting so much. It's nice and soft. I don't need to do that for the main incision because I've got the keratome, or got the para in there to hold it. So, entering right at the limbus, kind of in the horizontal plane, angling up, tunneling until the corners of the keratome are in there, and then angling down. Little wiggle gives me a nice rectangular incision. Yeah. Then we'll get some Fenlido in there. Now, Ian, you may feel some cool, comfortable water here. It may be cold. You know, sometimes, I want to be honest with you, it stings a little bit. But if it does, that's totally normal. Maybe get some dilation going here. What do you think? Should I use Trypan? Okay, fine. I'll use the Trypan. Sometimes you can see better than you think, you know?
I really need it.
I feel like it makes the capsule fragile. Sure. You do? Makes me pucker a little bit. I have a 76 micron nerve on one side on my left. Yeah, I think it's myopic. I need to get a follow-up, but I'm scared.
You should do it every year. And then these guys have been dilated.
You can like rotate this so that their oculars are like, I mean, unless you have a Hortner palsy and you want it like that.
You know what, the whole thing is actually rotated off. So like when you go on with your parent, it's like coming in from the other way.
The prism is right here. So, can we get a new pair of gloves for Dr. Kuhn? So, first, like, grab the thing, and so it's going to pivot at this joint. So, move the whole thing so the oculars are level.
Oh, yeah.
And then you can use the prism to line up the view. I mean, like, do you see this pivot point here?
That's better. And then I'm going to put that
Yeah.
there.
But push up on the oculars.
There you go.
Well, it looks like you got it. Okay. 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 So give me the Saba style Trypan with the bubble in it. Yeah.
With a bubble?
With the air bubble. I'll do it. I'll pull it back.
There's no.
Look at that perfect little puncture there. You can see that really well.
I did not.
Yeah. Okay, so we'll take some BSS to rinse that out, followed by the viscoelastic, and you may as well give it to me on a cannula if you have it.
Okay.
Yeah, thank you. So when I irrigate, I don't like to really go into the para or anything. I'll just kind of like go at the halfway in the incision like this, and then you can just kind of irrigate like this, and the fluid kind of goes in and out. So you don't like over pressurize.
Yeah, it takes a little finesse, not over pressure.
Yeah, and it's because it's sealed, right?
Yeah.
Like actually,
I've heard people doing that.
not even just like I want the bubble to come out, but it's not even disturbing the bubble. Yeah. Now we'll take the Utradas, please. I hold the Utradas like a pencil. This thumb goes right there. Your hands might be different size, right? So my thumb holds it, and that way I can take my thumb off of this one. So I can hold them loosely, and because if you hold them like this, it's like they move a little bit. But if you pinch your thumb on the hinge of it, then you can move your hands a little bit without it shaking. Yeah, I guess I do. I guess I do. And the other thing I'll do is like, I'll keep my hands like kind of on the speculum, like, so I've got this like kind of tripod here. It just helps to keep me really stable. Like acetylcholine, it does a beautiful job. But when your capsule runs out, you're going to ask for forceps.
I only started switching over to that recently.
This is the number one tip, is putting your thumb right there. Go ahead and try it. Yeah. But so this hand is going to stabilize too, so the fingers are forward, like this. Yeah, exactly, exactly. And this thumb is like right there. Mm-hmm. Mm-hmm. Yeah. Yeah, I can't really see my marks on the cornea. So when I make the rexus, I'll kind of like drag it at first. And then, not really focused. Okay. And then if I just trace my forceps in the arc of where I want it, I'm a little wide already. Awesome. I have a tendency to make them too small. So, yeah, it is. Well, he's young and healthy, right? Well, at least he's young. So I try to keep the fold radial, just like you're intuitively doing with your cystotome, like you can't really help it. But on the forceps, you can make the fold go any direction. So keeping like that fold pointing toward the optical center really seems to help it be round. And keeping the forceps like down on the capsule. Yeah, that's what you sound just like Offner. What if they move, Matt?
Or what if like I get a drop on the cornea, like somewhere would be nice. And then
It's like Dr. Offner. I especially tend to make it like too close to the center or sub-incisionally. You go out wide under the sub-incision, that's stressful.
yeah, I don't give myself enough exit. I don't want to hit it.
Yeah, well maybe that's why I do it too close, like I'm overcompensating, I look a little afraid. If it runs out under the incision, it's the most challenging place to bring it back in. Okay, so we got a decent little oval rexus there. I don't think there's any point in hydrodissection. Pardon me. So when I'm sculpting, I like to have the sleeve all the way back and the irrigation ports on the sides. Like so. And then to put it in, like, you don't need to turn it over, just kind of a little side to side. It'll often get stuck on the sleeve, right? Just like a little wiggle will usually get you in there. And some people are tighter than others. You could re-up my glidosoma, that'd be really awesome. So I like to kick on the infusion when the ports are outside the eye so I don't get bubbles. Or like a sudden like pressure wave that makes it uncomfortable for him. So go in wet like we talked about last time. So you see how the like speculum is like kind of occluding the eye. So with my left hand, I'm pushing on the bottom. I can kind of stabilize the speculum like that and make sure that I have a good view. Look how soft that is.
Yeah. It's the one.
Like it's almost no reason to even sculpt on this. Yeah. Connor, please. As my left hand comes away, the speculum falls down again, especially if you've got like a lower lid ectropion. So it can be really frustrating when you don't have good exposure. So I can keep my ring finger on the bottom of the speculum to make sure that it's in good position. But with the Connor, I can easily go under here. I mean, look at this. It's like there's not even any mass to it. But I still like to, because my vacuum apparently was immediately coming on at 350, I would always keep that second instrument in there to just keep the capsule back.
I can't feel it.
Yeah, I know you're not supposed to. You're doing great.
The eye drops are more painful.
Yeah. The eye drops were more painful, he says. Okay, so, wow, okay, that was easy. Viscoelastic on the left hand. So I love to go, I keep the phaco in the eye and just kind of offer her my hand. Right, so I don't want, especially in a young person with a formed vitreous. So then I come off the infusion, otherwise the viscoelastic just blows out. And then I can kind of fill up the bag. And sometimes I'll visco dissect a little cortex because, you know, I like to put the lens in while there's still cortex. So now it's a stable eye, right? I'm just stressed about it collapsing. No need for bimanual phaco.
Yeah.
Oh, that's so sweet.
Yeah. I don't worry about the axis yet because the lens is going to be spinning all around when I'm cleaning up the cortex. I'll kind of use the lens to squeegee the back of the capsule and to protect the capsule as I clean the fornix. And I know I'm not like really like cleaning it away, but I feel like just mechanically stripping it a little bit like this probably gets some lens epithelial cells, and then I'll vacuum it too. So same thing, I get maximum exposure on my tip in the port here, kick on the infusion, enter the eye slowly. Especially in a big eye like this, he's prone to feeling pressure. Is that okay, Ian?
Yeah.
All the big eyes get hyper deep.
Feel what?
Good. So, yeah, I know. So when I'll kind of push it to the side and kind of clean under. I like to kind of start from the back, you know what I mean? Because I don't want to take out the viscoelastic from the front yet. It's protecting the cornea. So I'll clean out the fornix and under the lens first before I clean out the cornea and the angle. It's okay, so I'm showing you bad form. I'm burying the eye, right? But if I bring my hand to the right, then I won't displace the eye superiorly so much. It seems like both you and Margaret have been taught not to go out under the iris with the IA. But it's okay to do that.
There's a lot of cortex there.
You kind of have to, yeah.
Yeah.
You don't want to leave a bunch of junk in the fornix.
The audio from the Centurion.
Oh, yeah.
Gives you a little bit.
Let you know when you're occluded. Oh yeah, as long as, so you can even engage capsule, but as long as you don't move it, it won't tear. Now with any single piece of acrylic, especially these Alcon ones, like what if I want to exchange it? You know, we got a immersion axial length, right? So I want to make sure that the haptics are really clean. So I'll usually kind of drag them into the center like this and make sure that I clean off the haptics, because otherwise they're going to be super fibrosed. You won't really be able to safely. There we go. You won't really be able to safely exchange the lens if they're really socked in there. You wind up amputating them or tearing the bag, and then giving the patient a monofocal. So now that also I can kind of squeegee the posterior capsule like this. I kind of scrape off, and then I'll turn it 90 degrees. And then I'll do this side, scraping that. Clean this fornix. Push it the other way, squeegee that side, clean this fornix. And Then the last thing I'll do back here is go under, because you don't want to trap viscoelastic back here, right?
That's one that I'm always like really shy to do. I tip my lens in.
Well, yeah, it's, so you just kind of push it to the side, and then if you rotate it this way, then a rotation between the fingers brings it under.
Oh, yeah, it's supposed to be.
It's just a rotational movement. The conner is the same principle. That's why I just love curved instruments. So now that we're kind of getting down there, I'm just kind of looking at the capsule, make sure I don't have a bunch of lens epithelial cells. Starting to look pretty. And I kind of bring it around, you know, to like 110 degrees or so. Oh, look at that. We got a little crud on this one. You see that?
Yeah.
We don't want to leave that.
I think when I put in PMMA, right?
PMMA haptics, yeah. Oh, come on. No, you're not. You can get a sample one and tape it to her arm and convince her. Yeah, but everything has acrylic on it, even the SC lens. It's got, yeah, polymethyl methacrylate. And it's an acrylic. Huh? Like, I don't know, maybe your ZA9003, the J&J silicone 3-piece. Maybe has different haptics. Okay, so before I come out, I'm gonna press my finger here. Mm-hmm. Mm-hmm. Proud of you. I wish I could remember the name of the guy who did that video. It was so funny. So then, so I'm kind of bending this toward the bevel. And then as I come into the incision, if the eye's flat, like I'll inflate it a little bit as I go. So I'm like pushing gently. Then like halfway through the incision, I'm going up.
Really on the roof, pulling up on the eye.
Uh-huh.
I feel like pulling up. Okay.
Exactly. So then I've got just a little bit of hydration in the roof of the cornea right over the incision.
It's like when the carriage coming, like make a pocket with the.
Yeah.
I was kind of like, that's a lot of extra steps.
Yeah, well, you can do it with the, you can do it with a needle too, like make a little poke
I'm gonna do it
and then
this
pull
way.
back a little bit, and then you kind of made a little Wong pocket there too, right? So poke, pull back, inject, and you know, you'll get the same thing. So look straight ahead, Ian. Oh, I think you'll see that there are 3 lights. Right, I want you to look at the space between them. That's different, huh? Look at the space between the 3 lights. So now my final positioning, well, let me see the axis marker. Thanks. So I don't mark them sitting up. But I'll kind of look at the limbus. You can see there's your 180, kind of like right there and here. Keep looking at the space between the 3 lights. Kind of magging out a little bit. So I can get a feel for it globally. 105. And if I make a puncture like right at the limbus, I just want to like nick the blood vessels a little bit so I get a little tiny dot, but I don't want to make a subconch hemorrhage, right? There you go. Keep looking at the 3 lights and the space between them. 90, 100, 105, right here. I've got 2 little marks to line the lens up with. Then if I press down on the speculum, then I can direct puncture because the eye's a little firmer, right? So I've really got to bring this one. I don't want to touch the center of the optic. So I can drag this one over here. And then that one there. But it's not on the visual axis, so I'm going to push it nasal. It really just needs to be parallel to that, right? Okay, Ian, focus on the space between the 3 lights. So if I line up my 2 little nicks here, Where'd this one go? It's right there. So if I kind of, see I'm pretty much parallel to that.
Yeah.
And then the light reflex is pretty much centered on the button. Now, this is like, you know, I'm not super OCD, but this is one step that I feel like is actually really important. Like, I think you need to get it right on there.
So too, because otherwise people are usually measuring like kappa, alpha.
So, those are my marks. So I'm parallel to that and the lens is centered, right? So what, and by doing that with the eye closed, then it doesn't seem to like, if you go into the para, you're gonna lose the chamber. Worse, you're going through the main, the eye's flat and it moves around. But this way the eye is like firm and stable and it's not going anywhere. See the Wexel, please? So if I check them here, I can see that that's dry and not leaking. Dry, not leaking. The needle track might have a little bit of flow, but those always stop. You can even see that if you push on the eye, it's not leaking at all. Even back here, it's not leaking, right? So it's nice. Oxydex. This goes into the main. You can futz around with the para all day if you want. Then you're gonna wind up having to burp it. So kind of go in like with the bevel sideways, halfway in the incision, and just irrigating gently. If you push too forcefully, you'll get champagne bubbles. Now, let me see the Wexel. I'll prove to you it's not leaking out either. See, it's still sealed. Even though you went into the main incision, just that little irrigation doesn't seem to make it leak. Now look down for me. Now, you will feel a little poke here, okay, Ian? What you're feeling is normal. Keep looking down. Good. I want to get as far posterior as I can. 5, 4, 3, 2, 1. And we're done, Ian. Good job. So listen, we're going to turn the room over, treat you like a new patient, do another timeout, and we'll do the other eye. All right, I think 20.